36-year-old gentleman who was attacked by bees while searching for lost goats in the forest with his relative on 12th of this month at approximately 7:30 a.m. So they went into the forest looking for the goats, and then he had grabbed on a branch by mistake, which had a beehive. And then the swarm attacked him. So the relative fled because there was not much they could do to help him and went back to the village to get help. They returned at around 11 a.m. And then this time, this man had somehow managed to crawl into a small grove, and he was covering his face and lying there, full face, lips swollen. He was conscious and was brought to CMC Ranipet ED for further management. Past history wise, he had no known comorbidities. He's a chronic smoker and an occasional ethanol consumer. So on examination in the emergency department, his respiratory rate was 32 and his pulse rate was 136. So he was tachycardic and tachypneic with a normal GCS, and GRBS was mildly elevated. He had multiple bee stings over the face and neck and abrasions over the limbs. But otherwise, systemic examination was unremarkable. So they managed with a bee sting anaphylaxis. So they've given him hydrocot, avil, adrenaline, midas, and then in view of impending airway compromise, they'd actually intubated and shifted to town campus and admitted in medical ICU for further management. So his baseline investigation actually showed HB of 19.4, that was probably severely hemoconcentrated during the anaphylactic episode, and then the rest of the workup was, the rest of it was mostly normal except for a mild increase in indirect hypobilirubinemia, and the baseline CKMB TROP-T was also normal. The ABG showed a type 1 respiratory failure, hypoxia, mainly 76, for which he was anyway intubated and shifted into the ICU. And lactates were 3.9, so tissue hypoperfusion was also there. So this was his ECG when he presented to Ranipet campus actually. So there are ST changes with significant elevation in 2-3 AVF with reciprocal changes. So suggestive of an inferior wall MI. So anybody wants to take a guess as to the diagnosis? He came in with a bee sting and then he had a massive MI following that. Anybody wants to take a guess?
Answer the question.
Okay. So the diagnosis of this syndrome is Kounis syndrome. Okay. So this is the this thing. So if you actually see his further investigations, interestingly, the CKMB TROP-T, which was 7.2 when he presented, had gone up to 187.2, and the troponin, which was 21.1, had shot up to 2,209. Additionally, he also had an elevated CPK, probably secondary to rhabdomyolysis at that time. And this was, I don't know if you can see it clearly on this, his urine was quite pink on the bag. And we had sent urine analysis, which showed just 1 to 2 RBC, and blood was 2+. But strangely, before we could further evaluate for that, the urine cleared up by itself. So we couldn't. But that was an interesting finding that we noted in the patient. By the time we got around to evaluating for it and looked at the repeat urine samples, they were all clear. So probably some transient hemolysis happened during the time of the anaphylaxis. So his diagnosis is Kounis syndrome. So coming to what I would like to talk about today, two parts, mainly this MINOCA, this is the new concept which we'll discuss. Are all STEMIs the same pathogenetically is the question. And the second is little bit about the Kounis syndrome itself and what we approach about it. So this is the concept that myocardial infarction with no obstructive coronary atherosclerosis. Normally, when we think of MI, we think that when we talk about coronary atherosclerosis, we're talking about the epicardial coronary vessels. That's the left anterior descending, left circumflex, and the right circumflex arteries. Those epicardial arteries are what, when we do a angiography, can we see the block in. So that's what we're talking about when we say coronary atherosclerosis. So this syndrome, MINOCA, is a distinct clinical syndrome characterized by evidence of MI with normal or near normal coronary arteries on angiography in the absence of any obvious non-coronary cause of MI. So those are the two criteria. One is that there should not be any obvious coronary this thing. The second is they should not have any severe hemorrhage or respiratory failure, like a type 2 MI, which can explain the findings better than this. So it should not have a type 2 MI and should not have any this thing. So this is MINOCA. So if you actually see the approach to MINOCA, the thing is you can either have large vessel causes or small vessel causes, that macro and microvascular. So for this epicardial causes is what we classically call the vasospastic angina. That is due to intermittent vessel spasm, coronary vasospasm. That is divided into two types. The allergic variant of that is what actually Kounis described first, and we call it the allergic coronary vasospasm, the Kounis syndrome. The non-allergic variant, anyone knows what it's called? Intermittent coronary vasospasm. That's what we call Prince metal variant angina. Okay, so those are the two types of vasospastic angina. Then the other is an eccentric plaque thrombosis. So the classic plaque we think of is, it's actually, the plaque is extending into the vessel lumen. But there are times when the remodeling happens in such a way that the plaque extends outwards, leaving the lumen of the epicardial coronary intact. But if anything happens to that plaque and it ruptures, it can cause a sudden occlusion. Thing is, because the plaque is not much in the vessel lumen, these things will just embolize distally, and by the time you do an angiogram, the entire lumen will be clear. So they can also present like this. The third of the epicardial is actually a spontaneous coronary artery dissection. That's the only other vessel pathology, large vessel, which can cause this kind of syndrome. In terms of small vessel, we all know about Takotsubo cardiomyopathy, stress cardiomyopathy, sudden unexplained. Again, we think it is autonomic or at some coronary microcirculation level changes are happening which are causing this. This coronary microvascular dysfunction is the same thing. We think that either spasm happens at the microvascular level or tiny emboli at the microvascular level are causing this. So the same pathogenesis in the epicardial can also happen in the microvascular level. The third is viral myocarditis. In a patient with no other explanation, you should think of the myocardium itself. And the fourth is a coronary embolism, although very rare. That can also happen, and by the time you get around to doing the angio, it could have either spontaneous clot could have lysed, or it could have embolized even more distally that you can't see it. So this is the approach to a patient with type 1 MI without a actual plaque which is obstructive, which is visible on the angiogram. So this is called MINOCA. Now coming to the Kounis syndrome itself, it was actually described from much earlier, but the first proper description saying that it is due to an allergic response was by Kounis in 1991. So it's either due to an allergic or anaphylactoid reaction caused by inflammatory mediators released mainly from activated mast cells. So you actually see in an allergic episode, as we all know, systemic vasodilatation, reduced venous return, leakage of plasma, volume loss, all these things contribute towards coronary hypoperfusion. Actually, this study has shown that up to 35% of your blood volume can leak out of the capillaries within the first 10 minutes of an anaphylactoid reaction. So 1/3 of your blood volume leaks out, there's significant hypoperfusion. But what Kounis syndrome, as we looked at the pathogens, interestingly is, they found that these mast cells are always present in the plaque, even with atherosclerotic disease. So it seems like these mast cells are there as a response to endothelial injury, like anywhere else in the body. And the purpose is that if your endothelium gets damaged, to prevent further hemorrhage and blood loss, these mast cells release mediators, which will cause an immediate vasospasm. So a plaque already has the mast cell sitting inside. It's not like we imagine that, they're sitting there in much greater concentrations in the plaque. And so when you have an anaphylactoid reaction, the degranulation causes massive vasospasm at the place where the plaque is present. That's why they go on to develop an MI, not like a systemic vasoconstriction like everywhere else that we see. So that is one postulated reason why the Kounis syndrome occurs and causes an MI. So if you actually see, based on this, the types of Kounis syndrome is subclassified into 3 types. One is in people without underlying coronary artery disease. 2 is what I was talking about, this pathogenesis. They have asymptomatic coronary artery disease. They have a plaque which is not at critical ischemic state. And when the degranulation happens, because of the high mast cells, the constriction there is more than the surrounding areas. So that is where the MI happens. And the third is, of course, if they've already had an angiogram and had a stent placed or instant rethrombosis, all these places also, they feel that the mast cell concentration is more. So if they undergo any sort of allergic reaction, the likelihood of having an MI there is high. So coming to our patient, the caveats were that, incidentally, if you notice, his GRBS at presentation was 250, which could have been an acute stress response, but his HbA1c was 7.3. On repeating the hemoglobin, his HbA had come down to normal after hydration. So we have to treat that as significant. He had a diabetes, he had features of acanthosis and peripheral insulin resistance. So till we do the angiogram, actually, we cannot classically say, but we are postulating even cardiophiles that this could be a type 2 Kounis syndrome. So we have treated him with antiplatelet agents and statins. Even in type 1 syndrome, actually, there's no contraindication to give it till you're sure that there is no other event that's happening. So his echo was completely normal. He had improved after this and he was discharged. His plan for follow-up on OPD basis. So to summarize, not all STEMIs are atherosclerotic. Think of MINOCA in an atypical patient. The Kounis syndrome and its 3 variants, and the reason why we think it happens correctly more over the plaque area, and that management may require treatment for both. Don't, just because it is Kounis syndrome, we cannot ignore the fact that he may have underlying coronary artery disease.
A nice presentation. Thank you.
Is there a difference in management of anaphylaxis in the setting of Kounis syndrome?
apart from a normal anaphylaxis without platelet?
So we give adrenaline, we give all those the same. What they do say is the MI management is different because beta blockers and all are contraindicated. If we are giving adrenaline and everything else, it can cause an unexplained alpha 1 activity because of adrenaline. That's the only thing that I read about. Yes, yes.
The only difference is here normally we give adrenaline.
Yeah.
Yeah. Line of management. But any hypersensitivity with ACS, if they are not in anaphylaxis, we are very cautious with
Giving adrenaline.
Because that can precipitate vasospasm. That is
For
only thing management is
different. Yeah.
Everything else is same. Second, I agree with you. Type 1, type 2, unless you do angio, you cannot.
Cannot provide. Till review, he's planned for cardio review and then further management based on that. As of now, he's continuing antiplatelets and statins. Yeah, I mean, it's not affordable, but that is a plan.
He did not get an angio.
He didn't get an angio done this time. Cardio is seen on IP basis. They've said to continue for now and they'll review. We didn't have evidence of a plaque in him strong enough to give it. And his echo was completely normal done 4 days after this event. So we don't have RWMA, we don't have compelling evidence to show that he had a plaque as of now.
How do you rule out the underlying atherosclerotic thrombosis and not?
Yeah, so again, it's only in the setting of an acute anaphylaxis that we can even consider this diagnosis. Otherwise, we would not. And
they presented the history of these things and then the ECG changes as well.
And he came in full-blown anaphylaxis. The face was yes, he came coming. So only because of that, this otherwise no other patient will be even considered this normally.
But a type 2 Kounis is actually because of coronary thrombosis.
Thrombosis. Yeah, but even there, the thing is, if you relieve the vasospasm, you can then plan the angio. It's not like that. That alone is the only reason why is what they've said. So we'll treat the anaphylaxis first and then proceed with an angiogram. Ideally, you need to proceed with an angiogram to this.
There's some scoring system. I was reading through this. Some Kounis diagnostic criteria is there, which I think it's all retrospectively only.
Nothing.
So history taking is very important. If the patient is not present with chest pain and has come with a B stain, you should think of this and not thrombolize at that point.
And interestingly, his first CK metropathy was normal. So the Kounis syndrome is known to occur after 6 to 24 hours after all these things have happened. So first CK metropathy was completely normal. The repeat one only showed the elevation. So somewhere along the way it happened.
Didn't he have rhabdomyolysis also?
He had rhabdomyolysis also. That also could have contributed.
That also would have pushed a CK.
Both.
So you want to ask something? Shall we go with the next thing, the paradox? Rajesh will be presenting from